Please join me in giving Dr. Josh Umbehr a warm Pachyderm Club welcome.
Definitely a pleasure and an honor to be speaking before this group again. Anytime we get an opportunity to share what we're doing about our model is a great opportunity. So I'll go over it a little bit again for people who maybe haven't heard it before, and then I'll talk about some of the more recent updates. We've been fortunate enough to travel quite a bit lately, spreading the healthcare solution that's kind of coming from the heartland. We started our insurance-free model almost 7 years ago with the idea that insurance is the wrong tool for the wrong job. When it comes to healthcare, the things we always assumed were that it was expensive. And if it's expensive, then you have to have insurance for that. And I think that kept us in a loop where we didn't innovate or find solutions. So much like car insurance, you have that to cover the risky things that are expensive, but you happily pay for everything else on your own because it's affordable to do so. So we just wanted to come in and build a better mousetrap. I often joke that it really came from the inspiration from my dad's trash hauling business, because it was the classic membership model. We, billed you once a month. We picked up four times a month. It just made sense. But then when I was introduced to healthcare billing as an undergrad at K-State, I saw the colossal mess that it was of coding and billing and adding a modifier and then a rejection and then a resubmittal. Doctors were making less money for their time each year because of added bureaucracy and paperwork, which on its face would be fine if that added value, but it didn't. It subtracted value and added delays and complications. So that was preventing patients from getting good care, doctors from being able to spend time with their patients. Now the most recent study says that over 51% of a doctor's time is spent facing the computer and doing paperwork, and only 49% is spent talking to the patient. So that's clearly a problem. So we built our model on a membership. $10 for kids, $50 for most adults through our corporate plan, for unlimited home visits, work visits, office visits, and technology visits. We have no co-pays for anything in the office, and any procedure we can do, we include free of charge. So that's stitches, biopsies, joint injections, bone scans, lung scans, heart scans, urine testing, strep throat testing, surgical procedures. But usually that's because those are something we can do at a very affordable cost. So something like an EKG is 36 cents for us to do. Yeah. The coffee in the waiting room is 60 cents a cup. So I should be billing Blue Cross Blue Shield for coffee. I'd probably get a better outcome on that. So it's amazing how when you rethink the business model, how much value we can bring back to our patients. We continue to push that envelope of value, and we do something unique where we dispense medications directly out of our office. So the larger idea is anything that we can do wholesale in the office, we try to. And often when we are able to do that, we get savings of 80 to 95%. So we've been to Bentonville to speak to Walmart executives at their invitation, and we told them we out-Walmarted Walmart. Years later, someone said, you're not supposed to do that. So far, so good. But Walmart will sell you 90 pills for $10. That same medicine, I get 1,000 pills for $8. So it's a broken market when I can outcompete the world's second largest retailer. That shouldn't be how it works. It's not how we expect value to be created. But they quit really creating value because of a insurance-based system that added bureaucracy and paperwork and hassle. So I don't know if Walmart's making a great profit off that $4, but I would guess not, because of the fact that insurance complicates everything and raises that overhead. So we've been able to do that even for things like breast cancer chemotherapy. We've gotten for 99% less, best case to worst case scenario. So name brand retail pharmacy to generic wholesale went from over $600 a month to just over $6. We actually gave away the first month of medicine for free so we could say Atlas MD now providing chemotherapy. So it's amazing what a new business model can do. We can do the same thing with lab testing. So a blood test that would normally cost you $50, we get for $1.65. Yeah. So it really challenges you to rethink this system. If the question nationally has been, how do we insure more people and make health insurance more affordable? Well, it's putting the cart before the horse a bit, because health insurance is only a payment model. If we're going to lower the cost of what it's paying for health care. So first we have to talk about that before we can really have a meaningful conversation about how we decrease insurance. And that's the piece we've left off the table. So that's the conversation we want to bring back, and we support insurance. We know we need insurance for the big stuff: car wrecks, cancers, heart attacks. But life insurance, I can only file one form with them. I can't file two claims on it. They seem to catch that. But health insurance we're using for everything. We're using for medicines that I get for under a penny a pill, and for blood tests that are under $2. Why? Because that's the way we've always done it. And I couldn't come to you and sell you car insurance that would cover gasoline. You would see that for the fallacy that it is. It would make no sense. Well, you can only use these gas stations, and you only get this many gallons of gas per week. And if you go to Oklahoma, we don't cover gas in Oklahoma. But that's what we do in healthcare. Taking a new model and rethinking it and adding value first, designed by subtraction, removing complexity, removing cost, then we're able to actually go to employers and help them as well. So we can help a small business decrease their insurance costs by 30 to 60% in the first year. Other employers we've worked with have decreased their health insurance costs by 75% over 5 years, even as they've grown. And everyone assumes that the insurance company is going to hate us for this. And in reality, we've tried to make this a win-win whenever possible. And we've shown with groups like Allied National, in fact, Dave Powell, who's the brains behind our ability to work with health insurance, he's here today. They have told us that their profit margins are significantly higher working with us as an insurance-free doctor than it is in the standard model. We just outcompete Walmart or Target or the lab or the pathologist or everything else. And instead of Zofran, a nausea medicine, Walgreens will happily sell you 30 pills for $120 if you have the coupon. We get them wholesale for $3. So if you're insuring it at $120 for every 10 days worth of medicine, you're paying too much for insurance and then the medicine. Just pulling that back and saying, actually, what we really want is less insurance or the right amount of insurance. Now I can afford outpatient care really easily. Now give me the insurance I want. I want protection from risk. The risk of hospitalizations or something bad happening or expensive chemotherapy, but I don't need it for 80% of the care that most Americans get. In fact, it's actually a little better than that. The insurance statistic is 95% of people won't spend more than $5,000 in a given year on healthcare. And that's in the bloated system where all these things cost too much. We can extend this over to state insurance, Medicare or Medicaid. We all know the state problems with our financial system with Medicaid. They're paying way too much for care. Well, now we can find a way, Steve Covey, third alternative-esque, of finding a way that 2 plus the people plus 2 for the state equals 6. In that if your state is paying $50 for a blood test I can get for $1.65, then we can make the left and the right happy. We can provide more care to more people, which is often the goal on the left, but we can do it in a fiscally responsive way, which is the goal on the right. We've maximized the budget 2, 3, 4, 5 times without actually changing the total dollars, which is going to be something great for the state. But everything in my mind is a jobs bill. If we can bring more jobs back to Kansas because health insurance is cheaper in Kansas, then that's a win as well. That's more money back in the pocket of employees. And again, getting broad-based support even from the insurance companies. So that's what we've been doing for the last 6 years in Wichita. We've been fortunate enough to help over 250 doctors convert to this model in the last few years and are viewed as an industry thought leader. We tend to get a lot of national attention. Sean Hannity has been excellent lately. He's taken this topic up and had us on frequently. But even better, that's rolled into governors calling us, senators calling us, and then yesterday I had the good fortune to go to Washington, D.C., and we were in an exclusive panel with Secretary Tom Price on how to lower prescription costs. which was interesting because it was mostly pharmacy executives there. So I'm normally pretty good at not making friends anyways. It was really easy in DC when you're talking to pharmacy executives. The CEO of CVS was there, for example, and this idea that some otherwise unknown competitor is going to come and take what they're selling for $120 for 30 pills and just cut that out to 3 was fairly intimidating to them. So I don't start my own car. I brought my dad for that. Yeah. Mostly because his life insurance was recently signed over to me. So if CVS does try to blow my car up, Keen will be missed, but his life insurance will not be. Yes. But the really great part about that was, while all the other players in the system were trying to fix it through the traditional way, I wouldn't say they're bad directly. I'd say that the sin that they're guilty of is unoriginality, or not inventing and competing like they should in a good market. They keep trying to fix it in the standard, well, if they actually argued to raise drug prices, because then pharmacists would be incentivized to keep people healthier, which would save money downstream, which isn't entirely wrong. But it wasn't the goal of the meeting. The question was how to lower drug costs, not how to lower downstream healthcare costs. So cutting their costs, they don't see a way to raise their profit that way. They need to get past that. This is why Airbnb didn't come out of the Hilton empire. It's why GM didn't create Uber. Often good innovation comes from outside the system, and that's what we're trying to demonstrate. There's still a way for us to all work together. I didn't tell them that, but I think there is. But if they don't want to embrace this model and provide a better value to patients, then somebody will. I will, or Amazon, or somebody. And again, we can apply that to private insurance. Uninsured people benefit from this because everything's cheaper. Privately insured patients benefit because their insurance is cheaper and has a better value, and they get all the care they need and want at a better price. But again, state insurance through Medicare and Medicaid would also benefit this greatly as well. In fact, the only person I hear talking about that is Wink Hartman, as he is on the campaign trail, pushing this idea for healthcare finding a better way, a way that benefits Kansas, and uniquely this is a heartland solution. Most people in those meetings with Tom Price are looking for layers. They were hoping for a value-based system, and thankfully, to Secretary Tom Price's credit, what he heard was more bureaucracy. They say, you pay us for value. If we make someone healthier and save you money downstream, will you reimburse us for that? And he said, well, so now we have to define the value, the metrics, follow them, pay more for them, and find a way to pay less for them when you don't hit them. So that's not what we're looking for. We're looking for a more streamlined system. Throwing more clay on this pile is just ridiculous. But removing it, design by subtraction to get to a streamlined, simple, elegant solution is the way. Block granting to Medicaid, so Medicaid would be free in the state of Kansas to incentivize patients to use meds that are a penny a pill and not $10 a pill would be a great way to do that. Thankfully, that meeting rolled over into more phone calls and follow-up meetings with other senior advisors at Medicare or with Tom Price, and we'll see where that goes. But I'm happy to answer any questions about how we work or where the model is going or risks and concerns.
Doc, let's talk about your pay. Are you sacrificing pay with your system, or do you make comparably what your peers, other PCPs would make?
We make roughly 30% more than the average doctor. Yeah.
So,
Why?
Okay, why? Because we're good. Because in a unique way, capitalism, free market business finds how to make competing interests come together. So we shouldn't be able to, we see fewer patients, we spend more time with them, we have a lower price point, but somehow we make more money. And that's because we design the system better. The average doctor has 5 to 7 employees each for the practice of billing health insurance. Well, then that means 90% of what they do in a year is paying for all their staff and overhead. So they have to see more people. They have to raise your insurance rates. It's sort of incestual system. When we pull that back, we don't need a lot of red tape or regulation. We have one staff member for every 2 physicians, 1 RN. So we actually pass those savings along. But the efficiency of having a membership-based practice where we can count on that means we can spend more time on patients and less time just doing paperwork or running a business. So.
Oh, it's just a thought. This isn't the question, but they're thought about changing your name to Doc Uber. So the question is this: right now we have a system that when you get to 65 or 66 or whatever, you have to sign up for Medicare, or there's a penalty for not doing that when you eventually do, or have to, or whatever. So is there a way around that? Have you guys figured out a way around that for old people?
I recommend don't getting old. Yeah. Stop collecting birthdays. Yeah. Quit counting. Yeah. Well, for what we find is a lot of patients, even after they hit Medicare, the myth is Medicare pays great for things. And when it pays great. What we find is a lot of patients can't get time with their doctor, can't get a phone call, text message, an email. They're traveling. They don't want to talk to the on-call doctor. They want to talk to their doctor. So these are all some of the things we do well. But also, anytime Medicare can find a reason to say no for something, they do. And we have patients who have been on medicines for a long time, and then they hit 65, and Medicare's like, that's a fall risk. So we refuse to pay for that. One great example is a friend of mine, another John. There's too many Johns in my life. Yeah. So he's a farmer, and he's riding the horse, and he gets some back pain. He needs a muscle relaxer. Well, he can ride his horse, that's fine, but Medicare says you can't have that pill because it might make you fall. Okay? So before, he was paying $40 for 30 pills. We get 1,000 pills for $11. So Medicare is forcing more costs onto patients because they're trying to manage this care. And what we would say is get out of the business of managing that care. If we made, if they have to do that because the meds are expensive in the traditional system, would just begets more paperwork, more regulation. And if you can lower that 80-20 rule, 80% of the medicines that people need down by 95%, like we're doing, well, then you just need less Medicare in there making these decisions. Same with blood tests, procedures, etc. So patients who hit Medicare, we always want them to check first. Best case scenario is you love us because we're us. That's great too. We're good, we're fast, we're convenient, we spend time with you. But even better is objectively we save you money. That's good profit. That's adding that back in terms of how a business adds value. And then that's what medicine is lacking, is doctors don't talk in terms of how do I add value to you. So one example that this room may or may not find useful is we get 90 Viagra for $30. Yeah. Sorry. What was that? Something that's normally $25 a pill, we get for, maybe 25 cents a pill. So, and that's just one of many good examples where we can add value back, but Medicare won't pay for something, and it's sort of this odd triangle. So that's where we add that value back. And that can be anything: cholesterol medicine, blood pressure medicine, etc.
Back here with Myron.
Yeah, since you have a really good working system, however, the federal government still requires people to have health insurance that they approve. How can they use your service and still meet the current and evolving Obamacare regulation?
Yeah, that's a moving target. Thankfully, Trump signed the executive order to say there's no longer a penalty for not having approved insurance. That helps a lot. But what the House passed would free up a lot of that if it gets through the Senate, where now the rules and regulations on what each state has to call essential benefits and things, that would help. We need more flexibility. And that's what David Powell has done for us for years. Pre-ACA, we could do this for anyone. Dave and his team could go in and take a person's insurance, just like car insurance. How much do you want to have? How good of a plan do you want? Customize that to your level. Post-ACA, we could only do that for employers. But with small businesses and partially self-funded plans, we have really, even from a legislative standpoint, our ideal scenario, really, because we can customize that with Dave's team to maximum coverage or maximal savings or something in between. That being said, the confusion is still out there because we don't know where it's going, and it's crumbling under its own weight now. So the old rules don't apply, and there's not new rules in place yet. So it's kind of an interesting scenario, but what we do know is we have more options than we had before, and there's no penalty right now.
So many of you have questions. I see your hands in the air. Just keep doing that, and I'll get to you when I can.
She does take tips. If you pay her dollars, you'll get faster responses to, yes. So hold your 20s high. Yes, it's always
Talk to us about, do you have any, for example, I need an MRI, I need an X-ray. Do you have any agreements with local vendors to provide those at a discounted fee?
Yes, we work with numerous vendors for things like that outside of our bubble, our office. So X-rays about $20 to $40, ultrasounds $100, CT's $200, MRI's about $400, and most of those are about an 80% discount. It actually ends up being cheaper without your insurance than with your insurance. We had one gentleman who, before he joined with us, paid $1,800 as his responsibility for an MRI of his shoulder with Blue Cross Blue Shield. And that same MRI with us would have been $400. So he could have signed up with us for the year for unlimited services and his MRI and had $600 left over.
How does this work with newer pharmaceuticals, for example, Trulicity, that's pretty expensive and fairly new?
Whenever it comes to newer pharmaceuticals, we start with the most cost-effective medicines first. The nice thing is we're not an insurance company. So if a patient wants an expensive medicine, we can prescribe it. The reality is something like that that's $600-700 a month may not be the best first place to start. So we can't change the fact that expensive meds are expensive. We try to be very clear on that. Some things are just expensive, but we try to make everything that we can affordable. So another medicine like metformin, I get 1,000 pills for $11. Do we want to do maybe 2 or 3 other older generics versus the $600 or $700? The nice part is now the patient is in control. If you don't like taking these pills or these side effects or these things, and the cost of a newer medicine outweighs the problem of the other medicine, great. That's a conversation we can definitely have, but a conversation you don't get to have with your insurance. A medicine you want or need, they may just say no to. But if we save you $300, $400, $500, $600, $700 a month on your health insurance premiums, it does open up more options for other medicines like that.
Doctor, your concept's very intriguing. I'm a firm believer in the marketplace and the laboratories percolating all around the country. Related to that, I have several questions. Bidding privileges. Do you have bidding privileges to all the hospitals in town? Secondly, how do you incentivize your patients to be better stewards of their care? For example, medicine or pharmaceutical compliance. How do you incentivize them to take better care of themselves? Smoking, drinking, seat belts, all those kinds of things we think about here in the wellness approach. And then lastly, what is Topeka saying about this? Why can't we have 150,000 of our fellow citizens needing Medicaid, and Topeka is obviously reluctant to add that? How can you get Topeka to add them and to encourage those Medicaid recipients to adopt this model?
Absolutely. I'll answer those in reverse order. Why isn't Topeka doing this? Because it makes too much sense. And because Wink doesn't live there yet. So, because, I think it takes a business person who can look at this by the numbers and say, this is innovation, this is value, this is improvement. And what we have with a career politician is someone who is very much in an old mindset of, well, this is the way we've always done it, and the way we're going to keep doing it. There are some legislative reasons. We've talked with this group before and developed a proposal of sorts, a general proposal, but would have saved Medicaid almost $2 billion. Well, the big thing that we ran into was there were legacy laws that if you don't spend it all, some of that money goes back. So bad government is bad government, and that's why we need a block grant from the federal down. Say, hey, let these experiments percolate. Quit telling them what to do. I was chairman last year for Rainbows United, a fantastic charity, I hope you're all familiar with. But one of the problems with going after state dollars was that, a generic example, if it was a $50,000 grant, it might cost $30,000 of the grant to comply with the grant. Well, now the state is just bad at giving out money. We can't even write checks well. I think the lobbyists all get paid. Don't worry, though. Yes. Don't worry, the lawyers will be okay. That's our new T-shirt. Yes. For all the lawyers in the room. So I think we could streamline that and make it easily adopted from Topeka out. What do we do to incentivize patients? I think one of the big barriers to patients taking better care of themselves is the cost of care, the ability to access care, getting their questions answered. FOBB, fear of a big bill. If I have to go to my doctor, and A, it's hard to get in, and B, it's expensive, and then I have to take time off work and upset my boss and do all these things, and I don't know what it'll cost to check my cholesterol. I think last time it cost $300, and I have no idea what my cholesterol medicines cost. So yesterday, Tom Price asked a question about cholesterol medicine, and we can get his cholesterol medication for the year for $3.65. So screw Walmart's $4 list. We've got a $4 a month list. We've got a $4 a year list. Okay. Now when patients hear that, they're like, oh, it's $2.50 to check your cholesterol, and it's $3 for the year to treat it. Oh, well, yeah, I'll check my cholesterol then, because now otherwise, if I don't know what it costs, and money's always tight, and now I've got to say I really value the knowledge of whether I'm healthy or not against the very need. The car broke down, the kids need something, this, that, and the other. They're incentivized to make other decisions. Or they're incentivized to make bad decisions on the cost of their care. A $10 copay for a generic and a $20 copay for name brand medication, what the customer, the patient, doesn't understand is the name brand medication might be hitting your employer's insurance to the tune of several $100s a month. Well, I was just $10 more, and I pay $8 for a bigger cup of burnt coffee from Starbucks too, you know. And we all understand a little bit, you know, for a brand name is acceptable, but they don't understand the information behind it. That, you know, my generic Lexapro is 10 cents a pill, or I'm sorry, Effexor, and name brand Effexor is $10 a pill. Well, which one do you want to spend your dollars with? And not Malcolm Gladwell. Not Mises, someone brilliant, not my dad, someone else brilliant, said the ways of spending people's money. You know, spend efficiently. Your money on yourself is the most efficient way. Your money on someone else's money on you, and someone else's money on someone else. Well, as long as you're spending someone else's money on the name brand medicine you want, we're making bad decisions. So we're incentivizing them with information on how to make the best decision for themselves, that removing other parties from this so that they can make a good decision directly. And then lastly, we don't have admitting privileges, but we do social rounds for our patients, which is more the standard, just using hospitalists in the hospital for those reasons.
Yeah, how would you rate the Congress plan on healthcare that we just passed? 100% down?
It'd be hard to put a percentage on it. And I'm a little bit, don't let perfection get in the way of better. Is it perfect? Probably not. Is it better? Absolutely. It was $1 billion tax cut. No, more than that. Yeah, multiple $1 billion. It was a fantastic tax cut bill because of bad taxes throughout healthcare. It did free up things. Did it get us all the way there? No, but I think in government we rarely get all of what we want. So let's not wait for that, because definitely all the piecemeal stuff as it comes through is a huge benefit to states and to employers, and we can march along. But I do think it's hard to get good ideas into D.C. For one, if you ask 99% of doctors what the solution to healthcare would be, they would say better insurance, because they're an insurance model. They don't even understand how to fix it our way yet either. Now that's changing as we help more doctors do this and get national attention and things. But So a very well-meaning senator could go and ask their doctor for recommendations and maybe not get the best answer or what we would call the best answer. But now that they are looking for that, I think Trump has set himself up to make big changes, huge changes. And so something's got to be sexy enough. And we think 95% savings on medications is that sales pitch that you can do. It's definitely worked for Hannity. People want better. Doctors and legislators actually maybe a little slower to adopt it because the devil's in the details, and there's all of this swamp of regulation. Patients just hear, it's a better product at a better price. In that sense, we're trying to get the legislation to catch up with the business model.
Your model is occurring in an environment where the Obamacare proposals often have either just one provider in certain areas, or maybe even in some counties, they've gone to zero. As we move in this direction towards 1 or 0, what's the likelihood that you'll have other folks following your business model and filling in those gaps where you've got a de facto single provider? Because the whole intent of Obamacare was to move us to socialized medicine, single payer.
I think the best thing that could happen out of this would be that as the Affordable Care Act crashes and Aetna and other groups pull out and now there's no coverage, it negates the law almost by itself. If Congress can't act, and not saying that's good or bad, then the market is still moving forward, and people are going to say, I can't be penalized anymore anyways, but now it's not even an option to buy. Maybe states will come in and do what Dave Powell did years ago, which was were we the first state to mandate light? Okay. First state to pass mandate light bill, which says in Kansas, the insurance companies can sell a plan that does not meet the ACA requirements. So even though it is law, and maybe at the federal level, maybe the states will come in and say, well, it's debunked and there's no one here to offer it, so we're going to allow mandate light plans, which is exactly what we had before and what worked. Now, less insurance is the better solution. We've always...
Custom designable, that's what I want.
Custom design. Do I want more hospital coverage, more cancer coverage, more prescription coverage? Well, I don't need prescription coverage anymore because I've got a doctor who does these wholesale. So I'll raise that up to $1,000 premium or deductible. That way, if I do get cancer or chemo or something very expensive hospital-based, I've got some coverage, but I lower my monthly premiums by changing my risk. So then everybody would find something that works for them. But I think that will be the pressure on Congress to act is, as we come up to major re-enrollment period, there has to be something there. But what I would say, again, Steve Covey, third alternative style, I want a plan good enough that Democrats vote for. I've got a few friends that are Democrats. I'm not shy about that. So we want a plan where they say, wow, again, this is better than either one of us thought about before. Is now Medicaid dollars are going to be twice as valuable, or we got twice the purchasing power. We couldn't, move mountains to double a Medicaid budget in any state. Now we get to help that many more people. Great. And if we can get that kind of logic going and moving forward, then I think we can get a plan that does pass the Senate. Because it's just objectively better.
Over here, Kathy.
I am guessing that after your visit to DC yesterday, your new best friend at CVS and all of his buddies raced back to their friends in Congress and all the lobby groups that they passed and are seeking to find some type of regulation that they can write into some type of law to shut you down. Mm-hmm. Or they may have already started that. How can we as citizens get the information we need about potential things that would stop you so that we as constituents can contact our folks and say no, because they'll probably try to roll it into some, other 2,000 or 3,000 page bill, and we won't know until it's too late.
Probably the best way for that is maybe follow our Facebook page or our newsletter, or you can always reach out to us directly. We haven't seen that yet. I'm sure it's there. We have been fortunate enough to pass law in almost 22 states now, I think one's pending, where they say direct primary care, what we do is not insurance. That was the biggest question. Of course, it's not insurance. We're not a risk-bearing entity. But we had to get some of these laws passed so state insurance commissioners wouldn't investigate and try to regulate and manage. And those have gone through surprisingly easy. It doesn't cost anything to do that bill. It's basic language. We can argue this is a win for both sides, yada, yada. So the next hurdle will be, what do they try to do to stop us from prescribing medicines? That's going to be a state-by-state issue for the most part, and I think the cat's out of the bag. That's going to be really hard. I would actually love to be a martyr in that regard. So, Keen Umbehr being the first Umbehr to go to the Supreme Court, I would love to be the second Umbehr to at least get arrested, I guess. My brother might have that title, but... because I think if they tried to come after us for this idea, like, you can't mark up meds 10%, it's like, great, let's have a conversation about who marks up what. Yes, I think that the public that'd be the best advertising I could get for free, because we'd have this national conversation about how industries that we trust, and I trust Walmart, Target, these companies generically to continue to compete and bring me better value. Last time I bought a TV at Best Buy, they said, you know what, we price match, let me step away and I'll check the websites for you, and if there's a better price, we'll match it. And they did. They found me a $300 savings, so I got it there. I expect Walmart to do that. So when a medicine could be a penny a pill and Walmart's not doing that, Walmart's losing trust. And what I would argue is Walmart doesn't even want to dispense medicines anymore. So in 2011, they were looking for solutions. Long story short, didn't find any. But what their goal was in the paper, the problem, health insurance premiums will crisscross household incomes by 2020 or 2025. So unless you can eat or live in your health insurance premiums, that's a problem. But it's a problem long before that for Walmart, because every dollar up in health insurance is a dollar out of your pocket that can be spent at Walmart. And they don't make the profit per retail square foot in pharmacy that they make everywhere else in the store. So what they really want, they may not be happy that we're out competing them, but what they really want to do is just get back to business at Walmart. So if we have a national solution that means better health insurance, cheaper health insurance, more jobs, more disposable income, an actual raise in effective salaries for the first time in a decade, then I think that's just a passing of the guard that they're going to be happy with. I would short sell Walgreens and CVS because their market, too much of their profit margin comes from the pharmacy side and not the retail space side. So they're going to have a hard time adjusting to that new model. And but what we have is an economic cartel. And again, cat out of the bag. We've already had phone calls this morning with senior advisors at Medicare that said, well, what can we do at a federal level to make this even bigger? So that's the momentum it'll go. They won't love it, but they'll find a way to work with it or go the way of Kodak.
Yeah, I was going to ask customers that have your program, they're obviously going to need some catastrophic coverage also to go with that, I think, to have them properly covered. Do you help us find those kind of people besides David, or do you have a list that you recommend, or just go see David?
Well, for the most part, we can work with any agent, but Dave and his team have been very familiar with it. A few others have learned it over the years, but it's a little bit of a nuanced conversation of how do you have to know enough about our model to know about the insurance to adjust that. So Dave and his team has done that the longest and has the best relationships with the insurance companies. So a group like Allied has more or less an exclusive arrangement with us for an additional 10% off your premiums after all the other discounts if you're using a direct care model. Not even just Atlas. There's other doctors we've helped start in Wichita or throughout Kansas. So as long as you're doing a direct care model, you get those extra discounts.
Okay, and then is your memberships for a year, 2 years?
Monthly. We know people hate contracts, hate lawyers first, but they hate contracts more, and the two tend to go together. So, so we want to keep it easy. We don't want you to feel like you're obligated to us for a year. You can pay yearly if you like and get a discount, but mostly it's just month to month to be as accommodating to the customer as we can be.
Thank you. Well, you're so far outside the box, I don't think you could find the flat. But where do you want to be in 5 years? How do you change your Walmart model into McDonald's and bring this to the whole country? Because what we're doing now in healthcare is just rearranging the deck chair.
Yeah, polishing brass on the Titanic there. World domination, that's always our... our stated goal. I probably should start with trying to win an argument at home first before I go for world domination, but it's baby steps. What I think is, you're right, darkest before the dawn. It's so bad and so broken, and we've had this model for 6-7 years, maturing and proving itself, and we've never changed our prices, so that delta always looks better in our favor. Now, hopefully, we're at or near the tipping point where even insurance companies want to work with us. We met with the largest privately held insurance broker in the country a week ago Monday, and they were shell-shocked. I had to pull up my wholesaler's website to prove the discounts, because they thought they already had discounts and mine were way better than theirs. But my paperwork is way better than theirs too. So, I mean, they started to piece that together, and what they're saying is, look, we're raising premiums every year, struggling to do that. We're not making record profits either. We're kind of hated by consumers. So if somebody can move in and move the needle south a little bit on premiums and on profit, then I think you'll see a car insurance style competition where now you have Geico and e-insurance and all these, born online and dedicated to saving. You'll have, if we can get insurance companies profitable again, and I know that always seems like a bad thing to say, they'll compete. If they compete, they'll lower premiums and raise benefits, but you'll use it less too. And in exchange, we'll have a better system. So I think we will see this hockey stick point in the curve where insurance companies don't want to work with doctors anymore. That's a broken model, and we're going to roll that out very quickly, because we want this. If you're not a doctor doing wholesale unlimited visits, no co-pays, free procedures, wholesale meds and labs for 95% discount, we don't want to work with you. We don't want to sell that plan. We want to sell the car insurance plan where you don't submit any claims all year, but we're there for you if you hit, car wreck, cancer, heart attack. So how do we teach the doctors? We offer all of our consulting free of charge. So we have a whole curriculum online for doctors in a starter packet, contracts, enrollment forms, vendor relationships, everything a doctor needs to start a practice like this, we put for free online. One, so they won't screw it up. Because doctors have never run a business before, so they don't understand all the simple nuances of running a business that could threaten the growth of the model. We want everybody to do it right the first time so it grows as fast as possible.
Okay, so this is a multi-part question, but I just want a clarification. Okay. So if I'm a family of 6, mom, dad, 4 children, that's how much a month? $180?
Within our employer plan, $140.
Okay, okay, so it's an employer plan. In Kansas, you have to have an employer. You can't just be a person going out and getting this?
You can. Our non-employer rated plans, $10 for kids, $50, $75, or $100 based on age.
Okay, so then I get that insurance. Then I go to Dave.
You get our care.
I get your care, right?
Then
I go to Dave Powell, and he provides the other insurance. So what if you get cancer and you can't treat it? That goes into the other coverage?
Mm-hmm.
Okay.
Yeah.
That's what I want to know. So this goes to David. If he can answer this, how much is the catastrophic insurance typically?
It varies by age. The group plans are a lot easier because we can put all the things together. Individual plans, until ACA is completely repealed, you're kind of tied.
Okay, thank you. Back here.
Is your Medishare, or is that different, or can you tell me the difference between you and Medishare?
Yeah, Medishare or Good Samaritan or Liberty Direct are some of the religious-based co-ops that were a loophole of sorts in the Affordable Care Act. They're not quite insurance, but they're sort of insurance, effectively. But they are much cheaper because they don't have to do the same essential benefits from a religious standpoint. Some are very religious, and your priest or pastor have to send in a letter that you attend church and live a clean life. And others are like, just be good. And so, because the idea is they're not going to pay if you wind up in the ICU for a heroin overdose, because that's not what they would consider biblical behavior. But they are very affordable. And that would be the insurance for the big stuff. And that's where we draw those lines of insure all the big things, use us for everything we can make affordable, because we do want to have a system without a gap. Yeah. And yeah, those do have a lifetime cap too. So there's that limit.
A lot of times you hear medical costs are so high because of malpractice insurance, and just driven by that. How does that affect your model, or how expensive is that not an issue?
I feel like there's another lawyer joke in there, but I feel like I've already beat up on lawyers, all right? So actually, yes, there's a lot of defensive medicine, which drives up insurance costs. And I think what it goes back to is the doctor's fault. I try to force as much blame on the doctors as possible, in part because we blamed everyone else and that didn't work. So the doctor's not spending time with the patient. They don't have a bond or trust or things. They can predict what surgeons will be sued in the next few years based on just the tone of their voice. If you sound like an asshole, you're going to get sued. I mean, that's the reality of that. If your patient doesn't like you, if they think you're mean, if they don't think you care, does my doctor empathize with me? And busy doctors are risky doctors. You're seeing 30, 40, 50 people a day. You're spending 5, 6, 7 minutes with them. 51% of your time is spent at the computer, and they're seeing the back of your head, most of the office visit. So then you miss things, and you forget to call back, and you lost that prostate cancer biopsy or whatever. So those are the things that lead to lawsuits, at least in primary care. So actually, our malpractice is 50% lower because the insurance company liked a few things. They said, A, you're seeing fewer patients, so it's kind of like you're a part-time doctor, and we already give part-time discounts, that makes sense. B, your business model means unlimited visits. There's no reason for a patient to not follow back up with you. Even you extend that to phone calls, emails, text messages, video chat. So if something's going wrong, there's no barrier for them to say, hey doc, I still don't feel well. Could we catch something sooner? But also all that communication is integrated into our chart so that we have this very great record of the conversation. But more importantly was the model builds trust. So our malpractice is significantly lower because of those things.
Doctor, it makes too much sense. Then again, I realize you are a K-Stater, so I understand.
Wasn't sure if that was a compliment or a cut, yeah.
Your father's driving is one thing, but I'd be concerned about a black Cadillac with a guy named Guido.
Yes.
I live in Hutchinson. You're really addressing more of an issue in your practice or something on a larger metropolitan area. What about the more rural parts of the state that have unbelievable demand because the doctors are not going to us?
Yep. Actually, we get this question a lot from doctors, and they always feel that the other side has the better opportunity. Urban docs have it easier according to the rural docs. Rural docs have it easier according to the urban docs, but both can play to their strengths and weaknesses. We grew up in a town of 900 people if you count all the cows twice. So, but there was still a doctor there, and in this model, the traditional model, you need 3,000 patients per doctor. In our model, you need 600 patients per doctor. You could probably even do less in a smaller town because your overhead would be less, and a lot of small towns offer subsidies and things. So it's actually easier, less marketing, less overhead. We had one doctor graduate residency, open in small town, Missouri. It'll come to me. Maybe a town of 12,000. But he had 150 patients in 2 months because all you have to do is hang out a shingle. Everybody knows that you're there. And we have another doctor in Buena Vista, Colorado, a town of 2,500, and they have 2 doctors doing this model there. So it really is something that works all over. Now, you might play with your numbers a little bit. If you're a town of 900, you don't want to exclude 300, so maybe it's $40 per patient per month for all 900 people, or there's flexibility to be had, but there's enough doctors to go around for all the patients in this model.
Over here.
Yeah, McPherson, great example.
Without getting yourself in trouble, what was Tom Price's reaction to you yesterday?
It was great. So everybody was being kind of squeamish about where to sit. And someone asked, well, where's Tom going to sit? And they pointed to the head of the table. And one guy just standing close to the chair grabbed the chair closest to him. So I reached across the table and threw my phone in the other chair. That's where I'll sit. And all, these CEOs and whatnot were, that's fine. So I got to sit right next to him, and everyone else talked. And then we went last, and the conversation got to be just me and him, because I won't really need to see their reactions. I know that'll be. But But he liked it. He asked good questions. His staff had questions afterwards. We have follow-up appointments. We sent them documents on our pricing so they could see very objectively where everything laid out. I was really proud with the industry leaders in the room were saying, well, we want value-based payments. If we save you a lot of money, again, like I mentioned earlier, then that incentivizes us to keep people healthy. And he rejected that idea, one, because doctors have dealt with that for a decade or more, and it has not worked well. And two, he just said that grows government. He does not want to grow government, or at least in that conversation. And he liked the less is more analogy. Let's incentivize patients because it's their dollars, and now it's so much cheaper and easier and faster. So he seemed to be very receptive to that. He said in the beginning that their stated goal was to bring something back to Trump that they could use to sell to the American people. But consistently, drug prices are the #1 concern from the voting public. And this is a very free market based approach that really requires almost no legislation. It's being done now. I don't need the government to say it, which is the best form of government, the government you don't need. And so they just like that simplicity, or that's the impression I've been getting.
So last words of wisdom from our dear friend George.
Josh, that all sounds good in theory. I've been a patient of Atlas for 3 or 4 years, so I can make a testimonial of how it works in practice. My wife got up this morning, she thought she had a urinary tract infection. So she went over to Atlas and gave a specimen, and the specimen was positive, and she came back with medication for it. And that all took less time than I've been held on hold waiting for other doctors.
There you go. Absolutely. I would say the sad fact is that's worth clapping over. My doctor was fast and helpful. This is amazing. Now, they should be so frequent that it's mundane, and that it's not says how broken the system is. Yeah. But thank you.
I want to squeeze one out. You haven't had too much luck with the state of Kansas. How about with Sedgwick County?
Sedgwick County hasn't done anything pro or negative, but we've talked with different groups in Sedgwick County about how employer groups, independent or government-based, could save money. One good example, without naming names, was they spent, a local group spent $96,000 on a name-brand cholesterol medicine for 64 employees that we would get the same, the generic equivalent for $3,000 a year. So that's the example that we're seeing in Sedgwick County. It's just same thing, same quality medicine, but the difference between a doctor who's writing out something that's easy to spell and something that's harder to spell. That's what it comes down to, yeah. We didn't go to school to be spellers, all right, or mathematicians. We're not that either. We're doctors. So when the doctor is so busy that they're not taking the time to focus on the cost for the patient, or they don't know, the doctor doesn't know, the patient doesn't know, the whole system falls apart because of a lack of good information. Well, thank you. Absolutely.